Welcome to the Shreds of Evidence podcast, where we look at the evidence, or the lack of evidence, the policies and the politics that shape the way paramedics deliver care throughout California. This podcast is proudly brought to you by Stanford Emergency Medicine and the California Paramedic Foundation. My name is Mark Cotreau, and I'm the EMS Division Chief here at Stanford. In the studio with me are Eli Carrillo, Director of Prehospital Education for Stanford's EMS Division, and John Earhart, a flight paramedic and a director at the California Paramedic Foundation.
Excited for this first case review. So I have a real interesting one for you. This actually comes out of a call that I was on. So I look forward to hearing from more paramedics around California, but just happened to have a really interesting case a few weeks ago. So I wanted to share with you all, and I think it'll be an interesting discussion. So for those listeners that don't know, I'm a flight paramedic and I work on a helicopter in Southern California. So we're often dispatched in as a secondary resource. A lot of, most of the systems in Southern California have multiple paramedics on scene. They're really requesting us for movement to trauma centers or, for STEMI stroke type activity. And then we also do in our facilities. But so we were dispatched, it was midday, dispatched out to a neighbor, a suburban area next to us. Based on that, the assumption's always going to be trauma. That's generally what it is. It can be peds, can be adult. Both of those receiving centers are distant enough away from that first responder community that they often call us to move them down within their time frame windows. Very limited details, dispatched out, just pediatric fall. So nothing further on that. Hoping as we get in the air, we'll contact them, get some information. One of the curious things that kind of piqued our interest was they often like to use, pre-canned LZs. It's just easier for them to secure. There's no dogs walking through. There's no bicyclists on a path or something like that. And certainly CHP hates when they shut down freeways. So they like the pre-canned LZs. And this one, they dispatched us to like a field, like a park next to a bunch of houses, which seemed atypical. So, we're kind of wondering what did they fall off of? Is this, were they on the roof? Are there any tall buildings in that neighborhood? What's happening with all this? We lift, we didn't get any details really at all, except that the LZ was secured. We landed, and then as we're walking up, they tell us the first thing out of the first responder's mouth is, "Hey, we're so glad you're here. This kid's not doing well." And we're like, okay, like what details do you have on this? And he's like, well, they'll have full report for you. We're like, well, what happened? How did he fall? And he fell on a bicycle. So, you try to, at least when you're going on call, maybe for the ED physicians here, you just walk into a room and you just get what you get, or maybe you have a radio call down before to start prepping. But as a paramedic, or at least in the first responder, you have so many activities you're trying to do at once that it's nice to be able to plan where you're at. So as just in that little short walk up to the ambulance, start thinking, okay, is this going to be an RSI? Is it a head injury? Are they seizing? Are we going to give Versed, Keppra, whatever that is? You start to go down that pathway. And super interesting. So we walk up to the ambulance, get in. They're BVMing the kid. Is about 10 years old. And the one thing that stood out immediately was I don't see any trauma on him. The two things. I don't see any trauma. No signs of external trauma to his head. Nothing. Just looks perfect. Except that he's ghostly white, like as white as a sheet of paper. So we jump in and...
Now, why would they BVMing him? Was he in respiratory failure? Or?
Yeah, at that point, he may be agonally breathing, but certainly not breathing well enough on his own. And so it was an interesting progression. You could kind of sense that he probably was doing better. And I'll give you guys some more details on this as we got more story later, but I want to keep it kind of in the frame we had. But that he was doing okay-ish with first responders and then suddenly not doing okay-ish. And so they just started switching to that, that in-between space where you're like, yeah, like they may be breathing on their own, but this is going the wrong direction. So we'll start bagging. And then I think by the time we got in, it was very close to him going into arrest. So.
Wow. What does it look like when you arrive? You said you came upon them bagging this 10-year-old, but how many people are there? What does it seem like?
I like to use, so Jerry Starkey, my paramedic instructor in Fresno County. I don't think Jerry was there, Greg, when you were in the Central Valley. I think he was probably retired already.
Probably not.
He called it the fishbowl experience. So this is a true fishbowl. I mean, you're landing, this is midday. lots of families around at home, kids out on bicycle stuff, right? And all of a sudden there's an ambulance and an engine in this neighborhood. And they're, piques your interest. Everybody's going to start watching that. And then all of a sudden this EC-135 Eurocopter flies in and lands in a field. So there's probably like 200 people from the neighborhood coming out watching. There's a whole pack of kids on bicycles on a driveway next to us. The ambulance is there. So there's an engine off to the side. The ambulance is there. They usually close everything up and kind of try to create like a bit of a privacy bubble. And all the providers were inside. And then the other thing that adds a little bit of stress to the moment is there's a crying mother that walks up. So right as I come into that side door of the ambulance, I'm trying to direct to get report along with the ED resident that's flying with us as a ride along. Or actually, he's a second rider now, so he's full-fledged flight doc. So we're trying to hear what's going on and try to get that first scene size up. And then immediately off the side, this mother comes up to me and says, bawling, what is happening? Why is there a helicopter here? And that's when I realized that, I mentioned that probably a quick progression for the crew, but probably for the family as well. They put him into this privacy bubble in the ambulance, and all of a sudden there's a helicopter landing. And I quickly realized she had no idea that something was going on. Their interest peaked. So
you said that he was ghostly white.
Yeah. So we jump in and we kind of that's the story. Getting the story is so important because once we're gone, we lose access to that, and we're the main conduit of information. So we're really trying to capture a lot of information. But in the scenarios where you size up and they're sick, there's some things that probably have to be done first, and then we'll come back and try to get that story. So I think everybody on the crew immediately switched into there's something needs to be done here. He doesn't look well. They're BVM him, but it doesn't look like he's breathing well at all, if so agonally. And my partner, kudos to her, jumped in, and as she started her assessment, the first thing she starts to pick up on is an early trend towards bradycardia. So she picked up on not only does he look horrible skin-wise, but whatever's happening is decompensating quickly. And she called CPR very early. So very, very quickly, just as he was going into a PEA arrest, she said, okay, let's get on. And she just assumed that role really well of managing a high performance CPR team, right? Really encouraging good quality CPR, managing, they already had access, which was great. They had an IO place. So we already had that. And then the ED doc and I jumped in and started doing an innovation. So not RSI, just classic innovation. From that point, you're starting CPR, you're still trying to figure out what's going on, right? Like, because you're doing these basic things. Okay, we have access, we're going to do CPR, but you're really looking for something you can fix, right? Do we need to do a chest tube? Do we need to, is it a head injury and a respiratory rest, or what's happening, And we're just kind of all scratching our heads, just working through the procedures, talking through it, trying to figure out what's going on. I think at that point, my partner was doing this very detailed exam and finally picked up on a small contusion right below the rib cage, like right upper quadrant, very light bruising, but no firm distension, nothing else that would just scream out to you like that there's so much blood loss that's why he's in this arrest. So it was very interesting.
Yep. How many minutes passed between when you went from he's white as a, ghostly white and I don't see any trauma to CPR?
30 seconds.
Wow.
Yeah. It was
how far out from the actual event was this by the time you guys got there and were assessing him?
So I think that they requested us pretty quickly. I don't know their dispatch time compared to ours. Our flight time into that neighborhood is very short. It's about maybe 6 to 8 minutes.
Okay.
Mm-hmm.
Like skid to skid. Like, so we lift off and we're landing. The flight down to the trauma center, in this case, the pediatric trauma center, would be about 30 minutes, 25 minutes. So by air. So it's going to be about 60 minutes by ground. I think that's one of the interesting things about this case and the outcome is just how the stars aligned with people recognizing things so quickly, and there's just being no gaps in that chain of activation or survival or whatever you want to call it. And then also just assumption of care, right? So the first responders immediately recognizing he's not doing well, starting to do supportive care, requesting more resources, and then us showing up, my partner recognizing immediately that this is trending towards CPR and getting that going. But the other thing that was kind of horrifying initially was, after we intubated him and are continuing CPR, really good quality CPR, his initial end titles were, if not 0, they were like 1 or 2.
Wow.
So you're like, this is not going to go well, right?
Yeah.
Yeah.
In a few minutes, we can talk about the need for intubation, which in air medical is different than in the ground, because once you put the patient in a helicopter, then your ability to intubate during flight is significantly compromised. And so it's very, very common practice to intubate prior to departure when you think you're going to need the airway. And this is certainly one of those cases. But intubation also carries its downsides. You're changing from negative pressure ventilation to positive pressure ventilation, which arguably he kind of already had. But, especially in patients who are hemodynamically compromised, that can be fraught with danger.
Especially in air medical transport, where you're dealing with elevation changes and all of the flight physiology as well on top of all of that. So you've got the intubation, and then in this patient, like a very obvious hemodynamic compromise, and then all the changes that you're going to have to go through with flight physiology. All of those are going to present challenges in this case.
Right. Especially if you're in the mountains and you're having to go to reasonably high altitudes. The most barometric pressure changes in physiology occur in the first 5,000 feet because that's where all the air is.
Yeah, that's a really good point. I mean, I think it translates to ground and air. I mean, air, there's certainly a lot of considerations because, to your point, there are limitations. I wouldn't say there's limitations. You could certainly do an intubation in flight, or you can do these other procedures, but it is drastically harder.
Yes.
But the alternative is also true. We really can't transport a BVM patient in the air ambulance because all the challenges that you have on the ground, right? You're going to move them to the gurney. You're going to move the gurney while we're rolling out of the house. And that gurney is always, placed at a max height for some reason, right? And then you have to tell them to drop it down, and then you got to load it, right? And you're doing those things. There's always interruptions to that care. It's just amplified in the flight, because you're going under the hot rotor disc, you're loading. It's a difficult gurney. It's more difficult than a nice striker. And then you get in and the patient's low to you. So they're below knee level in that airframe.
Yep.
And so, yeah, absolutely. We definitely try to do as many things that are going to be required as early as possible before we're going to go. But I think that translates to ground too. And that's something that, I did before I was flying, is try to position yourself for success. Like if they're down on the ground, maybe get them on the gurney and do an intubation where they're mid-height or a little higher to you, or all these little tricks like that. So yeah, it's a great point, Mark.
And then there's the balance too of, of course, his bad physiology isn't going to pause to allow for the exam or procedures. And so there has to be some thought toward continuous forward motion and getting him to where a surgeon can put a knife in the belly.
Yeah, that's a great point, because I drive that on calls that I'm on. At least I try to. I mean, we're all human. We, have our best days and our less than best days, at least in driving perfection that we seek. But that's my big thing that I tell people is, we're moving somebody, right? I had an old EMT partner back when I first started in Fresno that said, we have wheels for a reason.
Yeah.
You're trained to work while you're moving. So this is not a finish your PCR and then transport to the hospital type thing, right? Like, we should be moving.
Right.
And it's the same thing for our medical, like, pay attention to the things that you need to do for success early, but we should be moving, right? They're calling us to move them to a trauma center, to a surgeon that may fix this problem. It's not going to be us.
Yep.
We're not going to do anything in the abdomen to save this kid. So
one of my mentors, my EMS fellowship director, once made the statement to EMS that no IV ever saved a patient's life. And that, that's classically what happens is you have, patients sitting in an ambulance while somebody tries, several attempts at an IV, and, the patient is potentially critically ill. And especially in trauma patients where back in the old days, we used to fluid resuscitate patients, they would get a couple liters of fluid, and now we don't do that anymore. And so unless you're carrying blood, your IV is there for the convenience of the trauma center and isn't really necessarily therapeutic in of itself. And so hanging around on scene, whether you're in an ambulance or in a helicopter, to start an IV is probably not the best use of the patient's rapidly diminishing time.
Yeah.
Diesel is one of the best interventions that we have.
Absolutely. And that's for all those procedures, right? So the intubation, I hope most systems are doing this now, but doing continuous CPR while you're intubating, right? Using tools you have like bougies to allow you to intubate easier in those scenarios, but keeping that running forward.
And video laryngoscopy as well in there.
Yes, absolutely. And we carry these wonderful CMAC blades that are my absolute favorite, because you can do DL with them. just like a regular blade if you have to, but they're an HD TV, right into the airway. It's awesome. To your point though, Mark, we are actually carrying blood product now. So this is another huge consideration for us. And it's a reason that a lot of the first responders are requesting us early and often, and even taking us to scene, right? If they have a entrapment that's taking a long time, we've worked with them to say, bring us to scene, right? When you roll the dash off, you may get this bleeding or other things where we can hopefully maybe compensate that, right? And not with fluids, with something that may actually help the patient. So this is the consideration for us, right? It came in as a fall. We bring our blood with us, but there is some process to set that up. It goes through a warmer. There's extra tubing, right? It takes one person away from whatever's going on to do that thing. And this was a discussion point on scene was, are we going to blood resuscitate right now and stop motion of the call? And crew is working really well together. No, we're going to move, right? We're going to move to the aircraft, continue good quality CPR. It takes a second to get them loaded for the pilot to start spooling the engines up. We'll do blood then, right? Let's keep this ball moving forward because that's the ultimate goal here is to get to surgery, right? We were lucky that we had an extra crew member with us, the flight doc. So I did have a chance to step aside and talk to the mother, let her know, explain that he had gotten quite sick and that he needed a surgeon and we were going to take him down, that we thought he was bleeding in his belly. And then that went as badly as you would imagine it would, just generally for the crew and for the crew and the family. And then proceeded. So we just moved through back into the fishbowl experience, across the field, 200 people watching us do CPR on the 10-year-old and take him over to the aircraft. Loaded him up. Crew was awesome. I actually didn't ride in the back, so I actually got a break from CPR on this one and helped like do radio calls and things like that and talk through what was going on and kind of you can manage over the radio, right? But we only have room in the back for 2 providers. So loaded them up, started flying. Again, just amazing appreciation for the crew that was in the back. They were going crazy. I mean, they're doing one-handed CPR while BVMing, while the other crew's stripping out new units of blood product. The whole flight, continuous, amazing CPR. Not a great improvement in end tidal, nothing that was super encouraging, but we did start to see it rise. So in the 25-minute flight down, got an end tidal up to 6. So you're still kind of like, I don't think, not clear what route this is going to go. One of the really cool things was the early alert to the hospital. And I know we've talked about this before in our group, but there's a huge gap that can appear between the transition from the ambulance to the trauma bay, whether it's the movement in, where a BVM can be disrupted or CPR is lower quality, the report at the bedside, assumption of care. The trauma teams are really well-oiled machines, but it's a machine that has to turn on. People have to be assigned roles. There's discussions, right? And that can take no time or that could take a decent amount of time. This one was really cool. The children's hospital that received the patient sent their whole team up to the roof. They had the trauma surgeon up there, which was a rare thing. I don't know what it was. I don't know if something came through in the report that they just thought this is something that, I mean, obviously they knew the severity of the case, but I don't know if they thought, okay, this is something where, we need to get early report because we're going to assume care, or it just, again, as the stars aligning and they just had the right crew mix and they said, that's my personality. I'm just going to go to the pad and get the story and start taking over care gradually through the process. But like many hospitals, rooftop pad, down an elevator, around some halls. So there's this huge opportunity for delay, but all of that time was captured really well with giving a story, right? What did you find? What have you done? Letting them get their machinery up and running on what are the first things that we want to do? The positive improvement of blood. I mean, you have these signs, it's trauma, it's probably bleeding somewhere, but seeing the units give a little bit of positive change to the patient, I think is encouraging to them. So as we arrive in the trauma suite, there's a million people, right? Another, no longer a fishbowl experience for me, but maybe for the trauma team providers running that. And they assumed care. They started a mass transfusion protocol on them, continued to give blood products, gave calcium. They did actually needle his chest. So they thought maybe he had a tension pneumo. And I actually think that was from the CPR that we were doing. I think the tube might have just slightly migrated down into the right main stem. With all the action happening, one person doing CPR, I could just easily see, somebody bagging and doing CPR and having it slightly migrate down. So they did that. No harm in that, right? But didn't do anything positive for them. It was the blood. And
that's also sometimes just a routine practice in a blunt trauma arrest to the chest or belly, where, the potential for a tension pneumothorax is there, and it is considered reasonably good practice. It's actually considered bad practice to diagnose a tension pneumothorax by chest x-ray or CT.
Yeah.
And so a needle decompression in a case like this, certainly not frowned on if a paramedic does it in the field. And we could talk a little bit later about the success rate in, where to do this. But a chest decompression in these basically arrest or peri-arrest cases is not necessarily a bad thing to do at all.
Greg, you worked up, and when you were in pre-hospital, you worked in Fresno or in?
Nah, just a little bit south.
Bakersfield.
Yeah, Bakersfield.
Bakersfield, yeah. I think in the Valley, that was very common, Mark. They were told us on every blunt traumatic arrest, if there's anything from here to here, just do bilateral needle decompression. Yeah. I see it less in Southern California, actually, though, which is surprising to me. Well, at least on the ground, I did. Yeah, so one of the, again, like keeping the goal moving forward, I know they're not moving physically out of the room or doing different things, but they know the goal is to get to surgery if possible. And the thing that stood out to me in the trauma suite was that they just really pursued the mass transfusion. I think at one point I heard a doctor call out, like, why do I still see blood hanging in that bag? Get that blood into the patient, right? They just redirected the team to really focus on what mattered in the moment, not get caught in other tasks that are important, but not gonna, make a turn here in the case. So you can imagine here. So arrest on scene, maybe I think our on scene time was maybe like 8 minutes or so. CPR that whole time. 25-minute flight, CPR that whole time. They did CPR in the trauma suite for about another 20 minutes. So is that almost an hour of CPR, whatever that works out to? I'm not mathing it right now, and then they get ROSC. All of a sudden they get return of pulses and not a great blood pressure. I can't recall off the top of my head what it was, but it was something hypotensive, still tachycardic, but actually got ROSC. And that was where we, the crew, left him. They immediately rushed him up. There was a lot of coordination. They had the blood bank down because they're doing the mass transfusion. A lot of coordination to get blood to the OR suite, along with getting the whole team up there. So,
wow. Now, when did you transition from being bradycardic in the field, which is when you guys started CPR, to becoming tachycardic?
When they got ROSC. So they put in, so we got, I think, 2 or 3 units in. We carry plasma and packed cells. They were doing a rotation similar to that. I don't know if I don't think they were giving whole blood. They put in probably another 4 units along with some fluids, and we had fluids running with it as well a little bit. And so I don't know what's the circulating volume of a 10-year-old, but you have at least a couple liters of blood products.
That much.
Yeah. So yeah. So it was pretty crazy, and at that point, like our team's thinking, okay, well, what are the positives out of this? Because you start as an EMS provider, you're always trying to, land in a place where you, I guess, can process it or compartmentalize it and feel okay and move on to your next call. And we were like, okay, well, at least, if he got ROSC, like hopefully he survives, a little bit longer, family's coming down. Hopefully it's not this horrible, like I never got to see my kid again and they just got ushered away from me. And then I came to a hospital and found them passed away, right? Maybe they can survive long enough, the family can get here and the decisions can be made, things like that. So that's kind of where we left the call, flew back, we're just waiting for word, And then, so a little more details that came out on the following days. So they took him to the OR, they did emergency XLAP.
Wow. They
found a grade 5 liver laceration with hepatic artery involvement. They did a resection. They tried to stop as much bleeding as they could. I think he started to get a little bit cold, so they took him out, took him to ICU. Again, continuing tons of blood product. They did an emergency interventional radiology procedure where they actually went in and catheterized smaller bleeding that they couldn't get to the first time. That was really cool to hear about. There was a ton of coordination between the children's hospital and an adult facility that's near them because they didn't have anybody on site that does that. So normally they would move them to this other facility so they could be in their home environment and do those things. And they actually brought their team over, I think, and did this on site because they felt like he couldn't be moved. So that was really cool. Tons of coordination with the blood bank. I don't know, maybe you guys would have an idea. what the general blood usage is for like a hospital or a health system on any given week or something like that. But any ideas? I don't know. Like, what does an ED go through?
No, like not specifically, but with what you're already saying, that sort of idea of like a liver injury, hepatic artery involvement, essentially splenic destruction with a grade 5 splenic injury, that's going to require a lot of blood. Even in like ideal cases, if you shift gears and think about like liver transplant surgery, those procedures can take like 30, 40, 50 units of blood or other blood products in the process of, just doing one transplant. And so any sort of major bleeding in that area can often be like pretty catastrophic. And you can easily go through 2 times, 3 times, 4 times the patient's normal whole blood volume just in the course of your resuscitation.
Yeah. And I think one of the trauma surgeon followed up later and told us that the mortality rate for that type of injury is like 80%, even if they haven't arrested already. So it's pretty significant. So he ended up getting 170 units of blood over the next few days. There was some serious coordination with blood bank and resources. Went into, as he made it through kind of getting like the major bleeding stopped. I think when they initially went in, like just after the first, in the first procedure, they pulled like, I think 5 or 6 liters of blood out of his belly just for the listeners get an idea how bad he's bleeding.
I wonder if they auto-transfused him. Oftentimes, if in the operating room or even in the emergency department, if they're openly bleeding, then we can actually suction that blood, put it through a filter, and actually give it back to people.
That's a great question. I don't know if they did that, but that would be cool.
Yeah.
I'm going to ask somebody. I'm going to find out. Yeah, so they got the bleeding stopped, right? The major bleeding, but all the good things that come with trauma followed. MODS, his labs were all messed up, coagulopathy issues, things like that. And then, so that was maybe 4 or 5 days later after the initial injury. And then just all of a sudden, they said they were giving him everything. They're giving him blood products, giving him cryo, everything they could throw at him. And then all of a sudden, one of the next days, everything just started to normalize. So all of his labs started to normalize. And so we got that update, all of us in the pre-hospital community, and we're like, and we're adjusting our expectations of the event to say, okay, now at least, the family has time to consider what's going on, right? We don't know if he's going to make it, but now that he's really made it to that point where the family has time to process what's going on, and maybe, who knows what the outcome could be.
Yeah. And John, for our listeners, when John refers to cryo, basically what happens is you get a lot of coagulopathy.
Yeah.
It's similar to patients who are on anticoagulants who have head bleeds and things like that. And cryoprecipitate is actually clotting factors that we give to patients who are coagulopathic, which very, very frequently happens after large volume blood transfusions.
Yeah. And they managed to get that right. And then kind of letting everything settle in for the next few days. So maybe a week or week and a half, approximately in the timeline of this, they got to the point where they started doing sedation vacations, seeing where he was at. I think at that point they had done some additional imaging and they saw a little bit of a noxic injury, but nothing that, it was still uncertain. They were still like, we don't know what this means, like what this will be like in his actual function and how he'll be after if he wakes up and recovers. So a lot of open questions. They did some sedation medications. And I think the first thing that we heard brought some tears to everybody's eyes was that his sister came in and he actually looked at her and held her hand.
Oh, man.
So it was a really good sign. I think when his dad came in, he was talking to him and he was responding to that. They were noticing that he was, having increased reactions to that. Obviously, he was still heavily sedated, things of that sort. But so then all of a sudden your mind starts to run, you're like, okay, like this is crazy. What's going to happen here? And a few days later, they actually, so we're kind of, getting these delayed and intermittent, details, but we found out that they had extubated him. He was breathing on his own. And I think that the note in there said that he knew what elementary school he went to. He knew he played baseball and soccer. He was answering questions.
Wow.
So pretty incredible. And then he just rapidly improved even more from there. They transferred him. They basically had done everything. He totally normalized me. He was moved out of the unit. He was moved to do inpatient rehab, make sure that he was able to walk, do other things like that. But they rapidly found out that there wasn't much to work on. And he made essentially a full recovery.
Wow.
So he was up, walking around, talking, doing everything. So
those are career calls, man. You only get those,
seriously,
like every once in a while.
Yeah.
But
it's wild.
That's amazing. That's amazing.
Yeah, that's big freaking hero energy right there.
It's also, I mean, it brings up a bunch of important points.
Oh yeah.
You know, I've had a not anywhere near as dramatic, but I have to tell you that bicycle crashes scare the bejesus out of me. I had a similarly aged girl at a community hospital I was working in back east who came in crashing her bike and had the same thing. She just kind of looked pale. And during our evaluation, you know, she just started knocking her vital signs up a little bit, becoming tachycardic, and ended up that she had a grade 5 spleen injury, needed to be transferred to a trauma center. But that was one of those cases that reminded me that, you know, the handlebars on bicycles are kind of the seatbelt sign equivalent of motor vehicle trauma. One of the biggest predictors of intra-abdominal trauma is the seatbelt sign. And, you know, at least seatbelts have a little bit of give to them. They have decelerators built into them. Handlebars don't. And so even a relatively low speed impact into the unprotected abdomen with a metal handlebar has a high potential for injury. And so anytime I see that, I'm thinking, this is a trauma patient going to the OR until I prove it's not.
One of the other things that this sounds like is it sounds like really one of those great examples of just how fast pediatric physiology can change. You know, it sounds like from the story that you're telling before you got to the scene, it sounds like this kid had kind of been mostly okay, not okay, and then rapidly decompensates from there. And that oftentimes is one of those things that they warn us about in, you know, paramedic training, in hospital training, is that kids look great until they don't. And then when they don't, they rapidly go from looking great to, you know, and essentially, in this case, essentially needing CPR, needing dramatic resuscitation.
Yeah, we actually got more details on that, you know, after. It's interesting to exactly your point, how this went down is he crashed his bicycle. So he was riding with no hands. He thinks he swatted at a bug or something that shifted his body weight. So his parents said he does it all the time. He's really good at it. No issues. Swatted a bug, probably jackknifed the handles. I don't know if jackknife's the right term, but I think it's vivid, you know, and then gets the handlebar straight to the gut, almost like if you're jousting, right? And got up, was walking around, thought, you know, just shook it off, thought he was going to be okay. Then he threw up once, he vomited once, didn't feel okay, used his Apple Watch, or I don't know if it was Apple, smartwatch, to call his mother and say, I crashed my bike and I don't feel okay. And she said, by the way he sounded, she was concerned. So she was trying, you know, leaving wherever she was at the house to come immediately and find him because he's out in the neighborhood. A bystander actually saw him, I think, vomit and came to him and said he doesn't look good and activated 911.
Wow.
So it's kind of, you know, it very rapidly, right? And that was the scene. So at the first responders, we found out when they first got on scene that he was still entirely lucid, talking to them, just said his stomach hurt. So
yeah. Well, good on the bystander as well for kind of just recognizing that everything was not going according to, like, this was not a just simple injury. This was not a simple accident. This was one that had, you know, grave potential.
Yeah, sometimes that spidey sense.
Yeah, right. It makes you wonder if it took a while for the mother to get there and then she activates, or as we see a lot of parents do, I'm just going to take him to the hospital that's down the street. I'm going to drive him there, right?
Yeah.
If it takes that much longer for the first responders to get there, if they were activated, do they not recognize quickly that there's some sort of issue going on, and where's the resource to help this issue getting air medical there? Because it takes time for their flight suits to come on and helicopters to get turned on and lift and all that. And really the stars aligned in the amount of care he got, how quickly he got with the resources, and then the continuation of that. So it's pretty crazy.
You bring up one of the, one of the key points of this whole discussion is, it wouldn't have been at all unusual for this to happen and EMS to arrive and then the parents to say, oh, we'll just keep an eye on him at home. And it's really incumbent on the paramedic to be educated about the dangers here and communicate that concern to the parents and, let them know that, he's going to need an evaluation. If he had showed up in an emergency department not as a trauma activation, almost certainly would have gotten an abdominal ultrasound. We try to avoid CTs in this age group as much as possible. But if you can communicate that, he's going to get an abdominal ultrasound to make sure that there's no internal bleeding, and that sometimes the bleeding can be very, very occult until, it becomes very, very dangerous. That's an important thing to communicate when parents are making moves toward, refusing care and transport.
Mm-hmm.
It's not enough to just say, get the form signed in and then go back to the station. The paramedic has a duty to educate the patient or the patient's family into what the actual risks are as far as they can understand them.
Yeah, this reminds me of a case that I'd had at another point in time where that sort of thing the same sort of thing had been going on. They'd had a pediatric patient with an intra-abdominal injury, and EMS on scene had deferred to the parents to let them bring the patient to the hospital, and only discovered at the hospital that the patient had, high-grade splenic injury from their trauma, and as a result ended up needing a bunch of additional, resources, transfer to a specialty facility, all of those sorts of things. And it's one of those places where EMS can really make a difference when they have that awareness and say, look, no, I don't think it's a great idea that you just take your kid to the hospital on themselves. Let us take them. Let us go to that specialty center early. Let us get your kid to where they need to be as promptly as we can in order to minimize the amount of delay in recognizing any other sort of occult injury.
So, John, anything you would have done differently? I mean, this sounds like it went pretty well, from the first responders on to your crew and then to the trauma center. Sounds like everybody really kind of pulled together. Anything that in retrospect you may have done differently or at a different time?
Yeah, not on this call, right? I mean, everything worked out well. Obviously, the outcome is incredible. Child came and visited us at the base and was sarcastic and cracking jokes, and just a wild experience.
That's awesome,
right?
Yeah.
So certainly not on this one. And to meet the family, the full family that wasn't at scene, and grandma was in town and all this stuff. So no, call was great. The team was great. Very experienced crew. Also, very experienced crew working together. We've run a lot of flights together. We've flown together for 5 years. So no, it's just very seamless. But it does make me think, Mark, to other calls I've had, right? And where things have not gone as smoothly. And it makes me, we always do the best we can, and we always deliver high quality care to the best of our ability. But in everybody's career, there are calls that just don't stay on the rails like you want them to, right? Something gets in the way, some procedure doesn't go as quickly or successfully as you want. And so you start to think about those ones, right? And I think that's the cool thing about this story is perfect is the enemy of good, or you can never be perfect in what you're doing, but striving for that, because you never know when you're going to catch somebody at the exact right time with your skill set and doing that full continuum of care through to the hospital, and what that outcome could be and what that means to other people. I think everybody gets a little bit salty and pessimistic as paramedics, working night shifts into the week, and maybe they can lose track of that as well. So that was the other thing that was really awesome about the experience, was having that closed loop interaction with the family, really, at least for our crew and all of our crew that works with the immediate crew. It was a huge event to shine light on that and kind of refocus people on a patient and family focused, what's the right thing here for those people.
Yeah. And that brings up the, we often run these traumatic arrests, and the inclination in recent years has been more and more to pronounce in the field. And certainly that's appropriate when the patient's asystolic. The difficulty comes in when the patient's perceived to be pulseless. They might be in PEA. And that could either be what we used to call electromechanical dissociation, but very, very frequently, it could be just a very, very low blood pressure that is, you're not detecting pulses. Mm-hmm. And so perfectly reasonable to do CPR in these cases. We do CPR in newborns who are bradycardic, whose hearts are actually still beating because it's insufficient to give to perfuse the brain and the heart itself. But in these patients who are in perceived PEA, it may be perfectly reasonable to move forward to the trauma center and get that ultrasound done get the massive transfusion protocol started if that's appropriate. Most of these cases we'll lose, but the ones that we win stick with you for your entire life.
It also sort of sounds like a lot of the things that they're doing in like TCCC, tactical critical care, and all of those sorts of things where the emphasis is not necessarily directly on CPR, but on doing the intervention that is likely to restore pulses to the patient. For example, the gunshot wound to the chest that needs a needle decompression as promptly as possible, or the tourniquet on the massive hemorrhage in the exsanguinating wound, those sorts of things. Those are the interventions that can really make a difference in that kind of patient. And, early intervention like that can change outcomes. Obviously, as you see in this case, like it's a really great highlight of how every link in that chain of survival worked really, really well and did exactly what it was supposed to do in a critical resuscitation.
Yeah, I think, if you take a step back and look at it, I mean, I always told this to my interns. I don't have any interns anymore because I'm on the helicopter, but part of the role as a paramedic or even ED physician managing a team at hospital side is being the team coordinator, right? Running the event. There are skills we do that are critical, like the ones you mentioned from TCCC. But, and Mark, to your point about moving a call forward, right? Or advocating for a patient based on injuries with the parent, like that's a huge role for paramedics, right? Is to make sure it's not about the IV, it's not about the intubation, it's not about whatever it is you're doing. A huge part of your job is to drive quality of care through the system, right? This modern, awesome, incredible system that we've built, and ensure that that's running, right? It has the components there that can do incredible things, but as a paramedic, if you're not taking that on as part of your responsibility to say, what parts of the system does this patient need? Where do they need to be navigated? How do I coordinate the teams through those transition points? And so goals, like if you're a brand new paramedic intern or you've just got on the field, you're focused on not messing up too badly, right? Kind of getting your protocols under your belt and things like that. But I think it's a good goal for paramedics to strive to be a true pre-hospital leader like that, like to be a system navigator, to be a coordination of care, facilitator.
Mm-hmm.
Well, John, that sounds like just an incredible case, once in a career kind of case and a fantastic outcome. So what are some of the key points that everybody should keep in mind thinking about this and how this went forward?
Yeah. So obviously, awesome experience for us. Great outcome for the family. Maybe I'll get another call like this, but right now I'll say once in a career type call. So I think that, key takeaways for us that we got out of this experience was, early recognition of symptoms, right? By anybody in that chain of survival or the system has a chance to turn an event around, doing things promptly and quickly, but keeping in mind that we need to move the ball forward, right? What is the ultimate care that this patient needs? And to your point about that, this is a very dramatic case, but in any scenario, right? For paramedics is what is the ultimate goal here that's going to get resolution and the appropriate resources to a patient. Yeah. And then I think it would be awesome for us to, I would say I look forward to learning more from other paramedics that'll come on in subsequent case reviews and getting, information out of it, just like we have on this one. I think it'd be really cool to do a separate discussion on blood. I think it's something we started carrying recently in the last couple of years. We've had more cases than just this one where we've seen it have dramatic results. And that'd be a really interesting topic to discuss with you all.
Yeah, I agree.
Yeah, and it definitely represents a shift away from what we were used to doing sort of in the field earlier, which was, massive fluid resuscitation, and finding out that not necessarily the best idea. One of the other things that I heard you say that I think is a really great idea is sort of this idea that we've talked around about, is that surgery is the thing that fixes trauma. So moving toward getting surgery always is one of those important takeaways, especially in any consideration, is that forward motion is that important intervention.
Yeah, there's really no excuse for sitting by the side of the road with a patient loaded into your ambulance and not moving forward under any circumstance of a patient who's significantly ill, whether they be a trauma patient, a STEMI patient, a stroke patient, or a septic patient. Time matters in these, and definitive care. Obviously in trauma, the OR or the embolization suite, if that's the route they decide to go. For stroke, it's the thrombolytics, or again, the interventional radiology suite for a large vessel occlusion. and an embolectomy. And then for sepsis, it's antibiotics as quickly as possible. And none of those interventions are really available yet in the pre-hospital arena. So don't sit there by the side of the road, struggling to get an IV or making sure your entire history and physical is beautifully wrapped up. It's perfectly okay to arrive at the hospital with incomplete information and without the IV, because the definitive care is going to be taking place in the hospital.
Not even in the ER is the definitive care going to be taking place sometime. It'll be in the OR. And we got to get through all those steps to get there.
Absolutely. Well, it was nice chatting with you all. I look forward to our next conversation.
All right.
Yeah.
Thanks so much for telling us that story, John. That was good to hear.
Yeah, that's a heck of a story.
Thank you all for listening to the Shreds of Evidence podcast, dedicated to exploring the science and politics of EMS practice in California. This podcast has been made possible by a grant from the Bill and Christy Natick Foundation, as well as the California Paramedic Foundation and the Department of Emergency Medicine at Stanford University.